Assalamu alaikum. Thank you very much, dear colleagues and friends, Professor Juma, Professor Tare, and all other co-speakers. So what we are presenting now is a unique opportunity to present, for the first time, the results of an important study that my colleague, Dr. Jalal Nafash, in the previous presentation have alluded to. So we are here to present a prospective non-intervention study investigating glycemic control and treatment patterns associated with the use of once daily oral semaglutide in type 2 diabetes patients. The study was done on people obviously during Ramadan who wanted to fast and was done in 3 countries, Saudi Arabia, Kuwait, and UAE. Don't want obviously to go through the rationale of Ramadan, or everyone attending the conference understand the issues related to Ramadan and the problems of the fasting and the hours of fast. But specifically for an oral semaglutide drug that is new on the market, very important class of drugs. But we have heard before from the previous presentation, there are certain aspects to the drug. The drug as an oral GLP-1 requires specific restrictions, need to be taken on an empty stomach, need to be wait for 30 minutes before eating again, need to be taken with a sip of water does not exceed 120 mils, and deviating for this, we do not know whether the efficacy of the drug will be there or not. And consequently, if it's not efficacious, then the question mark, is this drug suitable for a Muslim person or not? Knowing that many actually do fast out of Ramadan as well. So these again are the practical points that one need to understand. The drug was tested for people to take it first thing in the morning after sleeping for several hours during the night, to take it, as I mentioned, with no more than 120 mils, to wait a minimum of half an hour without any food. And obviously we know that the drug comes in 3 doses. The start dose is 3 milligrams, 7, then after a month we increase to 7, and then if required we can go to the 14 milligrams. Knowing all of these restrictions, a group of us have got together before last Ramadan and we have put kind of like a recommendations for titration and administration. Many of the colleagues and the speakers of this conference are co-authors in this paper. And we said simply, let's make our best to ensure that the person during Ramadan would do exactly the same. So no deviation from the norm, and if they were to deviate, they should not deviate on many aspects. So perhaps deviating on one of them, for example, empty stomach or less empty, with a piece of date or not, with too much water or just half a glass, all of these points were addressed, and we suggested that they should not really be done frequently as deviations. So this Sema fast trial was trying to test all of these points. Will people adhere to this, and will the efficacy and the safety of the drug be sustained or not in real-world setting from 3 countries, Saudi Arabia, Kuwait, and United Arab Emirates? Our primary objective was really looking into the glycemic control during this month of Ramadan when people are fasting. And our secondary objective is to see whether this will have an impact on weight as well as the treatment patterns. Do people take it at suhoor, at iftar? Does any deviation happen? And if it did it matter or not? So again, as I mentioned, the endpoints is the HbA1c change from baseline to end of study. The secondary objectives were plenty. One is to look into the absolute and relative change in body weight. This is an important GLP-1 as a semaglutide. We expect important changes in weight. Hypoglycemia, whether it's self-reported or confirmed. Hyperglycemia during the month that leads to hospitalization. Gastrointestinal side effects. Change in concomitant oral therapy. Change in oral dose. Do people feel unwell and they are cutting the dose, or very well and maybe increasing the dose as per the requirement? Whether they are waiting the 30 minutes and whether they are taking it with the recommended maximum 120 mils, and whether they are waiting with the timing to take it after fasting. So a typical Ramadan trial, similar to what we see very frequently in Ramadan, is pre-Ramadan time, and then Ramadan, and then the follow-up time. Obviously, being a prospective observational trial, everyone was on the drug already, so they need to be already taking the drug for a number of weeks, and they want to fast Ramadan, and obviously above the age of 18 with a diagnosis of type 2 diabetes. Specifically, how close to Ramadan should at least they've been on the oral semaglutide? A minimum before joining the study of 4 weeks. So they need, at the time of joining the study, to be at least have been on the drug for 4 weeks before joining the trial. And obviously, we wanted to exclude all the classical exclusion criteria, type 1, those with serious problems, or pregnancy or breastfeeding, or mental incapacity or unwillingness to give consent. So we signed 305 persons. We excluded about 48 persons because they did not meet the criteria or dropped from the study. And then we looked into patients who attended intermediate visits were only 130, and patients with no intermediate visits was 127. Withdrawal from the study was 5%, only 13 persons withdrew from the study. So we ended up with completion of the study to 144, which is nearly 95% of the study. Patients on treatment at end of the study were 222, and discontinuing the study were only 19 persons. A small number of them because of safety concerns. The other were maybe because of the side effects. So if you look into the baseline characteristics of the people who took the part in the study, there's no major difference in gender, more male than females. I'm not really sure why. We see that in SGL2 trials, but not sure why it was in oral semaglutide. Average or mean age was 53 years, and those who are above the age of 65, obviously because of concerns about age, they were about 11%. The mean weight was nearly 90 kilograms with a body mass index of 32.2, which justifies the need for going for a GLP-1 receptor agonist. The mean weight is in the obese range. And those with normal weight were only 6.7%. So the vast majority of the trial are either overweight or indeed obese. Waist circumference would match that. HbA1c at the beginning of the study is very good. I might remind you again, these are people already on the drug for a minimum of 4 weeks. And it was quite a pleasant surprise to see that the baseline HbA1c is 6.78, nearly 6.8. With a sizable number, about 2/3 of the patients already with an HbA1c before Ramadan start of less than 7, which is the pragmatic target for many people. If you look into the fasting, we obviously know that some people fast out of Ramadan as well. So here you will see that some people are saying yes or sometimes, because obviously they're not fasting all the time pre-Ramadan. So pre-Ramadan, no is 75%, but 25% are either fasting or fasting some of the days. No Sha'ban and Rajab are many people fast during these months. Of course, during Ramadan, the vast majority, almost everyone fasted, either the full Ramadan of 85 or 15% fasted on some days. And actually, as you can see, 48% or 47% fasted some days post-Ramadan, which also give us an idea about the rates of fasting and the importance of knowing the efficacy and the safety and all of these issues, whether in Ramadan or out of Ramadan, because of all of these important points. The average fasting days per person pre-Ramadan was 5.6 days. During Ramadan was 26.6 days, and post-Ramadan it was nearly 4 days on average. Now, if you look into the duration of diabetes, the vast majority have a duration of diabetes of over 5 years. As you can see from the screen here, those who are less than 1 year are only 12%. Between 2 to 5 years are 23%. So about 65% have 5 years or longer, and a sizable proportion over 10 years duration. And the average duration in the study was 8.7 years. Of course, with such an age and such complication, you would have people with complications. Neuropathy was the highest rate of complications of 23%. Retinopathy was 8%. Cardiovascular disease was 21%. And 9%, sorry, cardiovascular disease was 9%. Retinopathy was 9%. I think of nephropathy was 8%. So there's no major difference between retinopathy and nephropathy, 8 to 9%. Now, why is cardiovascular disease high in this cohort? Because the investigators who are taking part in the study usually see people with longer duration and with more complex type of patients. It does not necessarily reflect the average. So the treatment pattern. Over 56% were on the 14 milligrams, on the higher dose, and the others were on 44% on the 7 milligrams. The 7 milligram is the beginning of the significant dose. The 3 milligram, as I mentioned, is the initiation dose. And the average duration of being on the drug before Ramadan was 149 days. So good sizable number of days, or converted maybe into months, nearly 5 months being on the drug with a median of 109 days. Other therapy is already there. We know the vast majority would be on metformin, a sizable proportion on sulfonylurea, 30% on sulfonylurea, and this is important to think of when we consider the hypoglycemia. SGL2 is obviously important class of drugs, and in the Gulf region, the use of SGL2 inhibitors is much higher than other regions. So let's now see some of the important results. The actual dose, did it change or not? Did people cut down on the dose of oral semaglutide from before Ramadan to actually during Ramadan or not? And as you can see, that actually is very marginal. So from 53% on 14 milligrams pre-Ramadan to 51 during Ramadan. So about 2% required to reduce the dose from 14 to whatever other dose they were. Probably it would be the 7. That's why we saw from 39 to 41. So the 2% loss here were gained in the other group. The other crucial point, did they wait for 30 minutes? Before Ramadan, 92% have no problem to take the drug in the morning. During Ramadan, 80% had no problem to stick throughout Ramadan to take it before iftar. And the other 16% were sometimes. So 16% were deviating, but not no. Only 4% were no, that felt iftar time is not the right time for me. It's adhan, my meal. That's what they wanted to do. After Ramadan, obviously, 91% were sticking to this plan. Now, are they taking it with 120 mils maximum of water or more? Before Ramadan, 85%. During Ramadan, 84%. After Ramadan, 95%. So the amount of liquid is not an issue. People are not terribly thirsty, even though the study is done in Saudi Arabia, Kuwait, and UAE, hot, warm countries, but it did not affect their sense of, I need to drink more. What about having it on empty stomach? Obviously, it means that when they take the tablet, they need not to eat. So before Ramadan is not a problem, during Ramadan is not a problem, and after Ramadan is not a problem. 92% are happy to wait for the 30 minutes. Maybe they will pray Maghrib or whatever, but this is quite encouraging that people, the vast majority of them, are sticking to the regulation. So if you look into the timing, so at some of the guys, as I mentioned, are fasting out of Ramadan as well. So that's why in this chart, you will see at iftar time, which is the dark blue, and that was 72%. At suhoor, that was 24%, answering the question of my colleague earlier. So a quarter of the patients are taking it at suhoor during the month of Ramadan. But obviously we need to remember people are fasting out of Ramadan as well, and understanding that's why only 89% were taking it early morning out of Ramadan. What about HbA1c and weight change? I remind you again, the baseline before we started the trial was less than 7. And we saw a very significant improvement in this trial of over 2% reduction from the beginning of the trial to the end of the trial, coming to an HbA1c that we would be any clinician would be very happy to see of around 5%. So reduction of HbA1c of 2% in an observational trial because people sustained taking the drug. This was not in this maintenance phase. They have started the drug not long ago. They carried on using the drug, and the effect is ongoing, and some of them intensified the treatment pre-Ramadan. So a significant reduction in HbA1c, whatever measure you would like to look into it, and also significant change in body weight. Very important change in the body weight that we have seen of 4 to 5 kilograms of weight, quite significant as well, with a p-value of 0.293. So it gives us confidence that such an important class of drugs could be efficacious for our patients and also very well tolerated. Coming to hypoglycemia. Sorry. So hypoglycemia increased, but as I mentioned, not in many trials of Ramadan, we have patients with HbA1c of 5%. On 30% of them are sulfonylurea, 90% of them are metformin, and 88% on SGL2. So this is triple to quadruple therapy for many patients. And getting to a stage of HbA1c of less than 5%, a co-chairman today had a study on multiple therapy during Ramadan, and hypoglycemia was seen even though many are not on sulfonylurea. So we need to be aware of this. So no wonder that pre-Ramadan there was 11% with hypoglycemia according to the patient's diary. During Ramadan that increased from 9% to 24%, and post-Ramadan it went down to 10%. So clearly this is a fasting effect in someone who is tightly controlled. Gastrointestinal side effects or side effects in general is what we expect to see. There was no hospitalization, no death, alhamdulillah, and nothing really serious with side effects. The severity of the side effects were really marginal. The vast majority of them were mild or moderate. Very minimal number had severe gastrointestinal side effects or any other adverse events. Why did who did stop and what did the side effects that they had? The vast majority of it is gastrointestinal, and some of them is hypoglycemia. So, dear colleagues, ladies and gentlemen, the conclusion. We saw a significant glycemic control reduction of 2%, and we saw a very significant weight reduction of 5.13 kilograms in this observational trial. Safety-wise, the drug was very well tolerated. Only a small number of people could discontinue the drug, even though that the initiation and intensification were overlapping with the taboo time of 6 weeks, do not touch, for a GLP-1, and this study was the first to tackle this by allowing people to do what they think is right. Hypoglycemia increased, and this is a learning lesson for us. For such tightly controlled people, the maybe other therapy or any therapy could be reduced, specifically 30% on sulfonylurea. We have not dissected the data of hypo according to which type of drug. The pattern of taking the drug with all the restrictions, waiting for 30 minutes, taking it with 120 mils, taking it in the morning after fasting, was adhered to by the vast majority of patients. Many, as I said, were already on other types of therapy, including sulfonylurea, metformin, and SGL2, and overall, it was really quite helpful. Of course, this is an important study. It does give us an idea about how can we get better glycemic control, better weight control, and it captures real-world pattern for a new drug that we are using, that an oral GLP-1 that in theory would have had some restrictions for a person with diabetes. Being an observational trial, of course it has its own limitations, and one would love to see more and more data in the randomized controlled trial. Thank you. I look forward to the panel discussion.